Abderholden has devoted her career to changing laws and attitudes that affect people with disabilities and their families. Since the fall of 2001, she has served as the executive director of NAMI, which we know is the National Alliance, the Minnesota National Alliance on Mental Illness. She's director for NAMI Minnesota. She's also had leadership positions within ARC of Minnesota, U.S. Senator Paul D. Wellstone, and Pacer Centers. Sue has a BA in this is fun, in political science from McAllister College, and also a master's degree in public health administration from the University of Minnesota. She's also a community faculty member for the U of M School of Social Work, and there teaches health and mental health policy. Now the thing I added, Sue, that happened after they sent me this bio is that you have also now been named one of the 100 most influential healthcare leaders in Minnesota. So I absolutely. So with that, again, Sue's going to present for us, and then in the end, we'll have an opportunity to ask some questions. In the meantime, using what we did from this morning, if you need to get up and move around, take care of yourself, absolutely we want that. There is a restroom if you go out here to the right. So with that.
Thank you so much. It's always embarrassing to have your bio read in front of you. I would also say for those of you whose feet are dangling like mine were, I realized there's actually a thing that can move it up and down, which I found quite helpful because I was like feeling like a little kid. And I will also say I'm also a family member. So I come to this also with the lived experience as a family member. So we're going to talk a little bit about the 2024 session. There was not as much money to spend as during the 2023, which remember there was a ton of money, right? Not as much because they kind of spent it in 2023. And then they were saying there could be a deficit in the future. They didn't use the word deficit, but that's really what they meant. They did not put much money toward the Healthcare and Human Services committees. They were really putting it in other committees. And at the very end, you might have seen this in the paper, they actually created what we call a megabus bill. Usually we talk about omnibus bills, which is like for all of human services or all of education, but they mushed it all into one huge bill. It was literally 1,492 pages long. Now, it doesn't mean that no one read it because people who are on like the Human Services Committee had read that section and things like that, but still, I didn't want to print out the bill for obvious reasons. And it was passed in the last few minutes of session, which was also kind of a nail biter, honestly, because we had some really good things in there. So we didn't get as much money as the previous year. The previous year, on how we counted it as directly mental health, was about $95 million. This time it was about $25 million. But the bad part about this is that almost 11 million of it was actually an unspent money from the previous session that the Department of Human Services did not get out the door. Now, normally what happens is that money goes back into the general fund. Luckily, Representative Liebling decided to capture it so that we could use it again. But these were important grants that didn't go out. Mobile and tribal crisis services, providing free supervision so people can get their license. We wanted to have locked residential facilities for adults who might need something that's a little bit more secure. So it was really kind of troubling. And CMEG is the Cultural Ethnic Minority Infrastructure Grants, which had been greatly increased. They'd really depended, frankly, on federal block grant dollars before. So we were very sad that that didn't get out the door too. So what we got was, we got $1.25 million for voluntary engagement, and then because of Senator Rasmussen, who is from Otter Tail, he got an additional $250. This is something I've been working on for several years, and we changed the Commitment Act so it's permissive for counties to do it, but nobody did it because there was no money. The worst part of my day is when I get a call from a family member who says, I can see my loved one struggling. I don't know if they stopped taking their medications or the medication's not working or what's happening, but I see those symptoms coming back and I know what's going to happen. And I call the county and the county says, they don't want to go to treatment voluntarily and they're not a danger to themselves or others, there's nothing you can do. And I just think it's fundamentally wrong. So we created this voluntary engagement, which again is in the commitment statute, so that actually at that point in time, you could send someone out like a peer specialist who would work for 90 days every day to engage that person in treatment. So it's not a crisis team knocking on the door and they say, you don't want treatment, goodbye. And it come in a very holistic way to say, do you have insurance? Do you have a provider? Do you have housing? Does the family understand means restriction for suicide prevention? Does the family know how to talk to someone who's having delusional thoughts? Really looking at that person holistically. And we truly believe, especially peer specialists, that they could get someone into treatment voluntarily long before they needed, crisis services, the emergency room, police interaction, or commitment. We want to avoid all of that if we can. And it's really about, like with any healthcare condition, right? Early intervention works. So now there will be, hopefully soon, kind of a request for proposals for counties to apply for it. We want to make sure there's the rural one. Otter Tail gets it because their Republican senator really pushed for it as well because of a constituent in his district. So I'm kind of excited about this, and I've been bugging the department about every week to find out, when are you going to put this out? Can I make sure I see it so you don't screw it up? But really to look at that. The next thing was to see if we can get Medicaid funding for first episode of psychosis programs. So a year ago, the Centers for Medicare and Medicaid Services actually put out codes that we could use. First episode of psychosis programs are really doing intensive services for people when they're having a first or early episode of psychosis. Because before, what happened is someone would, have psychosis, maybe they would get hospitalized, and they'd say, well, come back when you have stage 4, right? We didn't do anything intensive. First episode does it intensive, prevents people from becoming disabled, and really, enhances the quality of their life. The trajectory of those young persons' lives doesn't change a whole lot. So it's really important. We have 5 programs in Minnesota. Several years ago, when I used the New York model, it said we need at least 8. I'm going to be very honest, with legalization of cannabis, we're going to need a whole lot more. And so if we can get Medicaid funding to pay for it, then we can actually spread out those grant dollars so that we can serve more people. We also want to make sure that community support programs, which is kind of like drop-in centers, that it includes the clubhouse model, because we had some counties that said, no, you're not a community support program. Like, yes, it is. It's just on steroids. But and then directing the department to actually see how can we use Medicaid funding for clubhouses as well, like Vail Place. Adding occupational therapists to adult rehab mental health services. Occupational therapists really help with kind of engaging people in their community, thinking about work, friendships, lots of different, activities, right? So we thought that was good. We also wanted to make sure that for the first episode programs, that they could decide that someone is actually eligible for an assertive community treatment team. Those are really intensive teams, right? Because what would happen is that in order to qualify for ACT teams, you would have to be hospitalized a number of times. But the first episode program prevented people from being hospitalized. And so then when they were done with the program, they couldn't get the very services that they need to stay well in the community. So we changed that. There's also, the department created a commitment task force on the mental illness and mentally ill and dangerous commitment law. We've already started meeting. I'm representing us on there. Because the problem is when you go to St. Peter or to the security hospital, you stay there like an average of 7 to 8 years. And so we want to say, can we figure out a different way around this, right? Because some people, it really doesn't take them that long. They have kind of, these step programs, and then there's nowhere for them to go in the community. And so it's like, let's look at that and see if we can do better. And then another burden that we saw, kind of a barrier, was for our intensive residential treatment services, or our residential services for people with mental illnesses, is Minnesota Care didn't pay for room and board. So if you had Minnesota Care, it became very difficult to access that because there was no way to pay for the room and board. Now, we all know that private insurance also doesn't really do this very well, but we now have a mental health parity office in the Department of Commerce, and this is something, I had conversations with them last week, that they're looking at, is why private insurance isn't paying for it when they should. The 48-hour law. So this is like, several years ago, the sheriffs went to the legislature and they said, we have a person who is in jail, they've been deemed incompetent to stand trial, and they've been committed. And so once that commitment happens, they need to be moved to a state-operated facility within 48 hours. Well, back then it was okay, it was a couple of people, right? Now it's only people from jail who get into Anoka Regional Treatment Center. People from the community can't at all. And this is an issue not just in Minnesota, but across the country, that the number of people deemed incompetent has increased dramatically. We don't know whether it's just greater awareness about mental illness among defense attorneys, and county attorneys and judges, or is it a combination of, frankly, fentanyl and meth actually kind of creating, different symptoms in the community. No one's been able to know for sure. Now, I will say that Minnesota, we passed a law that created a competency restoration task force. We made huge changes that went into play in April. So some of that may change over time. And particularly, we wanted to make sure that people whose charges are dropped because it's a misdemeanor actually get connected to services, so we don't have that revolving door or that it kind of escalates into something more. In the meantime, while the task force tried to figure out a different way around the 48-hour law, did come in with recommendations. They're going to extend it for another year at least. They created criteria for who gets into Anoka first based on acuity. So maybe you've been in jail for a year, but your symptoms aren't really acute. Someone else has been in there for 3 months. They have really high, psychotic features and things like that. So, wanting to make sure that the person who needs it the most gets in there first. They also said that we're going to allow 10 people from the community hospital. We had a person at HCMC that was there for almost 2 years, maybe even a little longer than that, and they had to take beds offline in order to keep people safe, and yet we have people waiting in the emergency room to get into those hospital beds, so we wanted to make sure at least we could move some people. The other thing we know is that jails typically don't do many antipsychotics, and they don't do injectables. And for some people, injectables could really help them, right? So there'll be a pilot project to actually pay for and administer in some jails in Minnesota to at least start doing that. Also, we're again trying to create the locked IRTS facilities. The department had actually submitted something to the Centers for Medicaid and Medicare Services erroneously, not totally understanding the statute. And so CMS came back and said, you can't use Medicaid if you lock the facility. And we said, you can use Medicaid for someone if they're in a locked hospital unit. This is just a smaller place. But the department acted like the only people who got in there is if they were coming from jail. We said, no, they have to meet medical necessity. Some of them will be committed there. And there could be people from actually an inpatient hospital unit who could get committed to a locked IRTS. And partly around elopement, if people are worried about that in terms of safety in the community and things like that. So we're going to try again. And then just trying to free up the beds for direct care and treatment for our state institutions. We don't necessarily want to really add a lot of beds because it's not close to where people live, right? And so we want to try to create those alternatives in the community and prevent people from going there in the first place. On children's mental health, we got an additional $3 million for school-linked mental health. And school-linked mental health is not actually done by the schools. It's grants that goes to community mental health providers who co-locate in the schools. So you actually have a firewall between the education records and the mental health records, which is what families want. And then, of course, providers can build public and private insurance. And then the grant money pays for kids who are uninsured or underinsured, which is actually used a lot in suburban school districts with families who have high deductibles. It is a great program. I think it's a model, frankly, for the country. Unfortunately, in the previous session, they actually upped it for this biennium, but not the next. There's like a little bit of a cliff. We managed to get $3 million, but we didn't get it fully restored. And that's problematic, knowing what an issue our young people's mental health is, right? We really need to do this. So we got to keep working on that. We got more money for respite care. And I just want to say that you can never underestimate the power of a personal story. So we actually had a mom come down to testify, and it was kind of when they were putting the omnibus bill together in the House. And usually you get like literally 2 minutes, and the staff person is sitting next to the chair, timing it, and it hits the 2 minute is ended, and they put up a thing saying you need to stop now. Well, we had this mom testify about, she had more than one child with a serious mental illness. She talked about how important respite care was, gave her a break, she could recharge her batteries, and keep her kid, frankly, from hospitalization and things like that. We could see that they were getting to the 2 minute mark, and I saw Representative Liebling put her hand on her aides watch to let her continue. So she was able actually to continue her story, and we got $2.65 million more for respite care. And we were able to expand it too, because it was really just if they were in the hospital, but it's like, well, if you lost your in-home services, you need respite care even more, right? Because you're not getting that help. If you're using the ER, if your kid is stuck there, if you're using crisis services a lot. And then we want to make sure that families have access to regularly scheduled respite care. I used to be a respite care provider in Hennepin County. I had my foster care license. And when families knew it's like, okay, on this third Saturday of the month or this Friday night, I'm going to be able to drop my kid off at Sue's house, they could make it there, right? They knew that relief was in the future. Right now, it's not regularly scheduled in many of the counties, and that doesn't help families. They need to plan that ahead of time. Also looking at how can we use Medicaid for crisis residential for kids. The study that we did several years ago showed that families of kids who were in crisis didn't want like a small 4-bed facility. They said, we don't see how you have the expertise to help our kid. They really wanted added on to like a current residential facility, but there's Medicaid issues involved, so we need to figure that out so we can make that happen. And then there were still parental fees for residential for kids, and so that's been knocked out. So families don't have to be afraid that they're going to be owing tons of money when their kid needs residential care. Also, this is a little kind of in the weeds, but providers can decide which type of assessment to use for functional or level of care instead of the one the department said, which is good. Another good one is allowing Medicaid for psychoeducation for the family and the child together. And the other thing that happened is you can't bill twice on a day. So say you were doing the work with the family and then you were doing a visit with the child, you couldn't bill for both. And it's like, well, that's stupid, especially greater Minnesota, right, with transportation issues. So now you can. So we think that will actually open it up a lot. And then we've had this happen a lot with parents who have a mental illness. You can't put them into child protection just because of that disability. First, you have to offer supportive parenting to really, try to see if you can keep those kids and the family together with, of course, additional supports. On the criminal justice side, there's a thing called excited delirium, but it's actually not a thing. It's a fake thing that came up. And unfortunately, we saw across the country that police officers were using that as an excuse for intervening or having, well, it happened in Minnesota, having the EMTs give someone some medication to, calm them down because of excited delirium. It's not a real thing. Ketamine, yes. So now you can't do that. It can't be part of law enforcement training. You just can't do that in Minnesota. There's also a thing called an 1115 Medicaid waiver on the federal level that some states are now using, and now Minnesota has to put together an application as well. And all a Medicaid waiver means is that you want to waive current Medicaid rules because they're getting in the way of actually meeting people's needs. So in this case, they want to make sure that for people who are leaving the jail or prison, that they can access it. And it goes 90 days. So if someone's in jail and they're going to be gone before 90 days is up, you could use Medicaid then. Or you could use it in the prison as someone is going to leave in 90 days. This is going to be a while because you have to they put together a task force, then you have to do the medication, the waiver, you have to submit it to the federal government. It's going to take a little while, but it's still a good thing. And this has been in the paper a lot, including today. So we're saying instead of age 10, that a child has to be 13 in order to be charged in delinquency court. Because those kids are never competent to stand trial. I'm sorry, 10-year-olds aren't going to understand the criminal justice system even if they watch Law and Order 50 times, right? It's not going to happen. And we do need to take care of them. We do need to make sure we connect them to services, but pushing them into the criminal justice system, they're not really getting in there anyway. So we have heard that the Minneapolis Chief of Police wants to change this law back to the way it was, and so we'll be watching that this next session. On education, schools have to create a cell phone use policy, which we all think is frankly a pretty good idea because there's a number of reasons. One is just the distraction, but the other one is bullying. And so someone's not going to take your picture in the bathroom because they're not going to have their phone. They're not, they can't do those kinds of things during the day, which is really, it's important to have that relief for kids, frankly. So again, schools can decide how to do it, but I think it is a good step forward. Also, coaches have to have information about eating disorders, which is good because we see that a lot in athletics. So they are going to know more. We actually had a dad who came to us and a legislator, and his daughter had an outside therapist. And so she was in high school, and she just wanted to use an empty classroom to do her therapy visit. And the school said no. And we're like, so now it's in law. You have to let them. Sometimes you want to say, like, do we really have to do that? But we did. And so again, here's the dad just sharing the story of his daughter at the legislature getting some legislation passed. And then also the requiring mental health education for grades 4 through 12. Now, you all might say, isn't that great? Except there's no real curricula out there. And so we actually did a search of anything that was available, and there's not much available that teachers could actually use, right? Like NAMI has a program. We reached 9,000 kids last year with Ending the Silence. So we have a program that we can come in, but for a teacher to pick up a curricula and do it, it isn't. And after our experience about suicide prevention in the schools and how badly they did that, not using evidence-based practices, there was some school, there was an individual who had attempted suicide, and he went into the schools and shared every detail about it, which is the worst thing you can do, and it promotes contagion. We want to be very careful about what teachers can educate kids on when it comes to mental health and mental illness. School resource officers, SROs, now get to use prone restraints. Prone restraints have been banned in schools by anyone else using them. And you might remember the big fuss about now we're not going to have SROs and things like that. So the POST board, the police officer training board, has to create a model policy. It is now actually, if you dig deep, it's up on their website that you can comment on. But we want to make sure, you can do other holds. I don't know why they had to hold on to these. It's just not a good hold to use. But there were some issues last session. They did allow school social workers to start billing Medicaid for kids on special ed for certain things. There were some problems with the language. They fixed that up. And then school truancy is a huge issue. I would also call it school refusal and actually high anxiety. So you have kids who they're so anxious they just can't make it to school. And so they are putting a study group together to look at it because we think there should be other ways to address this. I think it doesn't make sense, honestly. One, we've had some schools, if a kid is truant, then they suspend them. I'm just trying to connect like how that helps. And then in some situations, they refer them to child protection. And yet you can have parents who are actively trying to get their kids to school, but their anxiety is just really preventing them. So at least we're going to look at some things, and there's going to be a pilot to see what other strategies we can use. And a bigger issue since COVID. On healthcare, so all of the hospitals, and as part of the Affordable Care Act requirements, they have to do a community health needs assessment. If you ever tried to find them, it's really hard. And we actually did a couple years ago, wanted to look at every single one that all the hospitals did. And it took a very long time by an intern to do it. And we actually found that mental health was always one of the top 3, not a surprise, issues. How they were going to address that issue was, frankly, abysmal. We will do one QPR training. We will do a Make It Okay presentation. I'm like, that's not going to address the mental health needs in your community. So to make it easier now, they're going to end up on the Department of Health's website so we can find them and really look into them. Another good thing is prior authorization is prohibited for outpatient mental health or substance use disorder, which is amazing. I mean, it's the cheapest thing that you have. Why do you put barriers to it, right? Let's make sure people can access, therapy. And you can't do it retrospectively as well. And then if you have a chronic condition and you've been prior authorized once, you don't have to go back if your condition doesn't change, which is also helpful to provide that continuity of care. Another thing is that if, for example, the health plan denied services, they could say, well, we won't do day treatment, but we'll let you do therapy. And that wasn't considered a denial of service, so you couldn't appeal. Now it is. And so if they make that decision, you can actually appeal it. And then if a hospital is going to close any inpatient unit, which would include mental health, they have to give a 182-day notice, which would give us all more time to, frankly, protest especially if it's mental health. On the housing side, this is something that NAMI worked hard on. So you might have remembered something in the paper about a year ago where in the city of Anoka, the police would, if they responded to a 911 emergency, it was a mental health emergency, they would write down the medications that they found and things like that. And then they would send a letter to the landlord and said, you should evict this person. Truly. And the Department of Justice came in and they fined the city and all this kind of stuff. But we also wanted to make it clear in our state law, it said that you couldn't, that a landlord couldn't, do retribution for someone. Because you have to remember what happens in cities is they say, if this apartment building has too many 911 calls, right, they can revoke that rental license. And so landlords don't want to see that. But we don't want someone to be afraid to call 911 in a health or a mental health emergency or domestic violence. Domestic violence was clearly in the law. So now we changed it, and you can't do it in a mental health crisis either. There's a lot of different supportive housing resources out there, and it's kind of a jungle. It's just really hard. It's complicated. There's lots of different ways. So they're going to actually do a work group to see if they could simplify how to access them. And then for the Minnesota Housing Finance Agency, for their programs, if you were eligible, for example, for general assistance, you're going to be eligible for housing. You don't have to fill out all that paperwork again because we already know you don't have any money, right? So trying to make it easier for people to access services. On the human services side, for people who are on medical assistance for employed persons with disabilities, which is a great program, so it really helps people work. You don't have to do a spend down to the poverty level. You just pay a kind of a premium, but it's low. And now the redeterminations are going from 6 months to a year, so that'll make it easier for people to stay on the program. The Min Choices Assessment, which is how you get waivered services, it's now good for 365 days. That was amazing because we saw people just, first of all, it can take 6 months to get that Min Choices assessment. And so if now it's not good after 30 days, you're just putting more people into the system that don't need it. And for a lot of people, their needs don't change that much in those days. So that, I think, is going to help. Sober homes is an issue that NAMI's worked a lot on because, of course, half of the people with a substance use disorder have a mental illness. So we actually care about sober homes. And we'll be coming in next session with more on sober homes. But one of the things that we found is that sober homes generally don't allow medication-assisted treatment, which actually helps a lot of people on fentanyl. And we had a lot of people with mental illnesses who could not access their medications, including antipsychotics, including medications that are not addictive. And so that was a problem for people, So now they have to, and I know it's, there's been a couple of articles like in MinPost, and I was called a dog with a bone, and things like that, which I kind of took that as a good thing, but I know they didn't mean it that way. But we have to allow people to have a safe place, and I'll talk a little bit about what we're going to do this next session. Assisted living staff now have to have trainings on mental illness. They didn't, and we've seen more and more people go into assisted living, both in terms of younger people with a mental illness, but also older adults who develop a mental illness. And then the elderly waiver has a lot less money in it than what's called the CADI waiver, which most people with mental illness use. And what happened is that if you were on the elderly waiver in a hospital, you couldn't get enough services to move out of the hospital. So now there can be an exception so that you can increase the amount to really help people move out of the hospital. On commerce, how many knew that long-term disability insurance doesn't treat mental illness the same way? 18 months is usually what you can get. No other healthcare condition has a limit. Mental illness does. We wanted to eliminate that. We didn't get that far, but what we did get is to say that the policy has to disclose that they treat mental illness differently. Because most people didn't know until they went to take it. And then it was like, wait, what the heck, right? Last year, we had actually changed the life insurance policy. So it used to be that if you took your own life within 2 years of getting the policy, your family got nothing except the premium back. So we changed that to 1 year, which is a step in the right direction. But it also had some weird old language in there like, sanity or insanity. It's like we don't use those words anymore. So we just updated the language. And then, of course, it makes it illegal to deny medical care due to medical debt. On the mental health care side, 988, which I hope everyone knows and has put it on their refrigerator or everywhere you can. There's actually police cars, and I think it's Le Sueur, Minnesota, that now have 988 on the police cars, which I was like, it's a woman police chief. Just saying. Just saying. So anyway, but we set the fee now at 12 cents, so that's good. This is a weird one, and even I don't understand it, but it has to do with coding. So there's coding in Medicaid that's different than coding under private insurance, commercial insurance. So they want to change some of the children's coding so that more services get covered under private insurance. That's basically what that means. And then for children's mental health providers, doing a streamlined certification. So if they do a number of different services, they don't have to do all these different applications. Rates. We all know that one of the reasons we have a crisis in our mental health care system is that we depend on Medicare much more than, and Medicaid much more than any other health care, and Medicaid rates are low, very low. The department came in with a study showing that we don't even cover the costs of most of the programs. And so we got some more money. So there's $5.7 million for hospital inpatient mental health and substance use disorder. Substance use disorder got a 3% increase, which the mental health providers did last year. And then they've appropriated $1.6 million for 2025 and $8.4 million for the next biennium to increase rates for mental health to be 83% of Medicare. It's kind of how they do it. So it's an increase, but we need to do a lot more. And then one of the ideas we had is that, we have a lot of grants in the mental health system. Could some of them be formulas? So for example, crisis services cover all 87 counties. Why do they all have to apply for a grant? Can't we just distribute it to them using a formula based on, maybe, poverty and distance and population and things like that, which would then, because what happens is the department never gets it out in time. And it's a lot, and then they're without money for several months, so it's like, this would be easier. We'd like to see it with schooling too, because they make that a competitive grant, and so you can have a provider working well with a school, and then all of a sudden they lose that money to give it to somebody else. And to me, that's rearranging the deck chairs on the Titanic. If somebody's got the grant and they're doing a good job, why would you take it away and move it around? We just get more money and keep expanding it, but quit moving it around. On the workforce side, they repealed the limit on physicians' assistant scope of practice. So prior to this, they couldn't diagnose or develop a treatment plan for someone with a serious mental illness because they have a lot less training than other mental health professionals. And so we lost on that. We tried to come in with different things. There's a national certification program for PAs on mental illness. We thought if you do that, then we're okay with it, but we couldn't get any of that. So. A great thing that the Board of Social Work did is there's an alternative pathway now for social workers to get licensed. The national organization that does the social work test found that people who didn't pass were either male or women of color. Well, then the test is really geared towards white women. And we need social workers, and just passing the test doesn't mean you're necessarily going to be a good therapist, right? And so they're creating an alternative pathway, which we would like to see for all the mental health professionals. Because we need a more diverse workforce, especially. Now there's the LPCs, licensed professional clinical counselors, joined an interstate compact along with social workers. So what that means, if you're a state that's in that compact, you can practice in any of the states in the compact. So if we're in that, that means that, and if Wisconsin's in it, that means therapists from Wisconsin can actually practice here. We clarified that clinical trainee includes those waiting for licensure. So there was this weird gap. It's like you finished your hours, you were waiting for the test results, and you couldn't bill during that time. So we fixed that little thing. And then we had a supervision program that started actually 3 years ago that would go to clinics, for example, to provide supervision for free. So it could pay for that supervisor's time, and you had to have a certain amount of Medicaid, because we wanted to make sure that clinics that took a lot of Medicaid, who probably couldn't pay people as much, could recruit more people to work there because they provided that free supervision. There's now an advisory committee for the new direct care and treatment agency. So if you didn't know, basically state operated services is going to be its own agency and not part of the Department of Human Services. We absolutely supported that because we had one agency that was providing licensing and funding itself, basically. That's not good. You need more sunshine on things like that. There's a guardianship task force to look at, are there alternatives to guardianship that we could do so that, it is tough when you're under guardianship for folks. So this is kind of interesting. Several years ago, and we thought it was always in law this way, that the assistant commissioner was only over mental health and substance use disorder. And then all of a sudden they changed it because we complained about how the disability division didn't understand people with mental illness with waivers. So they said, oh, we'll make the assistant commissioner over disability and housing as well, which meant that mental health got less attention. So we've been complaining, and so now they finally went back and said, okay. I will say that they changed the name to behavioral health, which none of us liked because these aren't behaviors, they're symptoms. It's to say mental health and substance use disorder. Does it really take that much longer to say it? But we lost that one too. And then the Human Rights Act was changed to include impairments that are episodic or in remission, which will really help people with mental illness in terms of their rights under the Human Rights Act. So that was kind of the 2024 session. So not as much as the previous year where we got a lot of different things, but we still made progress. And as you know, I always like to say our mental health system isn't broken. It was never built. And so every year we come in, adding on things, tweaking things, to actually make it work. So we're going to come in the 2025 session. We've been told there's no money. Now, I keep listening though, and I keep hearing that the tax is doing okay in Minnesota, so there might be a little bit of money in there, and we'll be watching very closely for that. So a big thing is we just have to keep focusing on rates. We've got to get the funding up for our providers so that they can, pay back their student loans, they can hire people, we have people to work in here. If you saw the article today, Kids Residential, they can't hire people. They make more money at Burger King. And we're talking about working with kids with complex needs. We need them, right? And so we need to include the rates. We'll continue to look at workforce issues. This last session we had a bill that would have created a mental health and substance use disorder workforce center at the Department of Health. Nebraska did this. And what they found is because when you had someone focused on it, like how many people are going into the field, how many people are getting licensed, how many people are leaving the field, who's in the field? Can we reach out to high school students to make sure that they understand this is viable? Can we have it at one place, one-stop shop so that you can see the differences between the different licenses, right? And which one do you want to do and things like that. We want to continue to grow that supervision program because we know there were like several thousand people who finished grad school and didn't go on to become licensed. And we did a non-scientific survey, but the number one thing was I can't afford to pay for supervision and then do the supervision hours while I'm not getting paid. It's just too hard to do. So we need to continue to address that. And then we wanted to do kind of a grow your own, and we're going to use the dual pipeline thing that the Department of Labor has. And so it's kind of like, maybe there's a receptionist at a community mental health clinic. She's interacting with people with mental illnesses all day, and she says, I think I'd really like to be a therapist. Well, why don't we help her, right? It's someone who's already, it's kind of like what we do with paraprofessionals in the schools to become special ed teachers. They know what the work is like, and so they're more likely to stay in the field. So we're going to focus on that too. We need to do a lot in the children's mental health system. Some of it is just really infusing more money in, especially for in-home services to help families, but we also want to update the language. Right now, we don't call it mental illness in the Children's Mental Health Act. We say emotional disturbance or serious emotional disturbance. Like that makes you as a parent feel any better? No. And for many families, they confuse it with EBD category in special ed, and then they think their kids have a diagnosis when they don't. So we're just going to say mental illness. We're going to just move it back. The other part of the language is that in the Children's Mental Health Act, they keep talking about out-of-home placement. It's not out-of-home placement. That's child welfare language. It's residential treatment. So we want to make sure that language is clear. For 20 years, we've been trying to separate out child protection and children's residential. We created what was called the third path. So first we created voluntary so that families could just voluntarily put their child into treatment through the child protection system, but not have to go to court. And they still retain rights over their kids. Well, then when they changed the Family First Act on the federal level, we couldn't do that anymore. They would still have to do a relative search. And our families were like, a relative search? And my kid needs residential treatment, and you're going to do a relative search? No, that's not going to work. Plus, we had families whose kids were LGBTQ who said, the county can invite anyone to the table, and I have an uncle who's homophobic. I don't want him at the table talking about my kid's treatment. So we created a third path, which meant that the state would pay for room and board. Because the only reason we had to go through child protection was because Title IV dollars, federal dollars, paid for room and board. So we said, we'll just put our own dollars in there. So we did. Unfortunately, during the conference committee behind closed doors, the department added language that no one knew about, or they didn't talk to any of us about, that actually screwed it up because the per diem rate that they pay for room and board is so low that no residential facility could do it. So we're stuck still in the child protection system. So we're coming back to fix that. The other thing, oh, it went on the wrong line, sorry. It's the Health Professional Service Program. So when you have a healthcare professional, mental health professional, maybe they have a substance use disorder or a mental illness, they can go into this program, not lose their license, right, as long as they follow a treatment plan. It is very outdated. It is so outdated that people who are making the decisions aren't even mental health professionals. You aren't allowed to use your own provider, so you're paying now out of pocket for an out-of-network person. I had someone I know who was using truly a nationally known psychiatrist for integrating mental illness and substance use disorder, had worked at NIMH, and they rejected his treatment plan. I'm like, I'm sorry, no. So we're making some changes there to make sure, again, that people aren't caught in those kinds of things. NEMT is non-emergency medical transportation. And so we want to create a child mode for that because we're having difficulty transporting kids to day treatment because most of the non-emergency medical transportation providers won't drive kids unless the parent's with them, which, you know, if you're a working parent, that makes it really hard. We want to change some things around case management. PTSD does not qualify you for targeted case management. And what we've been hearing from some of the BIPOC mental health providers is that they don't really diagnose people with borderline personality disorder anymore, that it's really about PTSD and the trauma that they've experienced, but then they won't qualify for case management. So we're going to change that. We also want to add anxiety as well to that, so we'll see if it works. On the employment side, we have IPS, which is kind of the evidence-based program for people with serious mental illnesses. Works really well, but we've not been able to move the needle on funding for years. I will say that for 21 years, I tried to get a meeting with the Commissioner of Deed, truly 21 years. I had one, and then he became the editor for the Star Tribune, so I missed out on that. But finally, last month, I had a meeting with the Deed Commissioner. I was like, yes, now I can retire. And really talked about the importance of the IPS program. This program is so effective, but if you go to the Deed website, it's not there. And I'm like, here's a program specifically for people with mental illness, and you don't even list it on your website. So we had a good conversation, and we'll see what happens. On the housing side, in addition to having more affordable homes, we want to change up the sober home some more. So if you're poor, you can't afford to go to a sober home, right? But if you take government money, we want you to be certified. Because we have plenty of horror stories to say. There are good sober homes, no question about it. They play an important role. But we have had horror stories from people. We had actually a friend of mine, her son, who had a brain injury, has schizophrenia, had addiction, and he used. And so at 3 in the morning, they dropped him off at Hennepin Avenue. Needless to say, he got beat up, ended up in intensive care for over a month. And so we need to have, I understand you can't use when you're in a sober home, but you can't just, people are still vulnerable, you have to figure something out. And you should meet some standards. I mean, we've had people tell stories about, infested with mice and, just all sorts of things. So we need some standards around it. There are national standards, and so I think those are things that we should look at. We want to streamline kind of mental health providers so that they're not, different definitions between if you're a crisis provider and, an arms provider. It's like there should be some similarity. They call it uniform, kind of a uniform code. So there'll be some things along there. We also want to do some things around tardive dyskinesia. Because a lot of people actually don't know about it, and it's when people take antipsychotics, and then they start shaking and things like that. If you stop it early, it's not going to get worse, but people have to know about it. So we're trying to figure out how to make sure that people have that education. With crisis services, you might have heard the story in Ramsey County that they were charging people for crisis services. I'm sorry, no, that was never, ever, ever the intent. So we're going to make sure you can't do that and make sure that health plans can't charge a copayment for that as well. And then we did submit a letter already to the Commerce Committee because you have to do that by August 1st, looking at first episode of psychosis under private insurance. Because a lot of those young people are under 26, which means they're on their parents' insurance. And again, we want to build out this program because it's so effective, and so that's something that we're looking at as well. So I want to encourage you to stay informed. There's a legislative update. It probably went out at 11 o'clock this morning. I think I timed it to do that. Every Sunday it comes out, except if it's a holiday weekend. It shares more information than you probably ever wanted to know about what's happening on the state and federal level. But especially during the legislative session, you're going to know what bills are up, what we need calls and letters for, things like that. We also have a thing called NAMI Smarts, and it's a class to kind of teach you about the legislative process and how to have an impact. And I will just say, it's people's stories have the largest impact. And so, you'll see on our site, we don't say send the same letter to everyone because that doesn't work. I would rather have one good story going to a legislator than 10 that all say the same thing. And because a lot of people don't really write about mental illness, it only takes 1 or 2 or even 3 letters or emails to make a difference. So it's not like I have to organize thousands of people for a legislator. I just need 2 or 3 people to do that. And so questions. And we have this little box that we have to use if you want to ask a question. And we can throw it at you too.
She said, okay, shall I hand it to you? I think this must be the.
Okay, I have several questions, but I'll just start with one. So the MAEPD one-year determination is great news. So that means they could only raise your premium or lower your premium once a year, correct?
Yes.
Yeah, that makes sense.
I feel like I'm doing
Beth.
like a talk show thing or something here.
Hi. In the summary that was shown there, you talked about repealing limits on physician assistants.
They repealed the limits. Yeah. So they can treat and diagnose even serious mental illnesses now.
That doesn't sound good. And what about nurse practitioners?
No, they can. They're considered, nurse practitioners are considered mental health professionals. Physician's assistants are not.
Okay. Thank you.
They operate under a physician, but.
You can throw it to her after.
Okay. Oh, it is throwable. I thought, boy, I don't want to hit.
I know.
So I'm carrying it, but you're welcome to.
Good to see you, Sue. But I do have to say one thing. You're not allowed to retire. I'm just saying. With the truancy piece, and because I have unfortunately some skin in this game right now, personally. What is same kind of thing with just writing up your story? Do you have any thoughts about more that can be done to kind of support movements there?
One thing I noticed in the statute is that after, I think it's around 2 weeks if a child's been absent from school, the school no longer gets money for that child. And I think that is a disincentive then in some ways, right, to keep working. And I think, again, if the parent, is engaged and is trying, and, the school is trying to, and it's not working, we shouldn't be penalizing anybody for that. We need to figure out how to help that kid. And I think some of the school-linked mental health providers have been really good about this, but we don't have enough, and there's waiting lists. But I think we have to change the statute so we don't have that weird incentive in there.
Yeah, thank you.
Thank you again for this incredible talk and all the amazing work you do, Sue.
It is a coalition. It's not just me.
I know. So after hearing all this, you're saying that there's really no mental health system. It's not a broken system that hasn't been built in the first place. And so, and clearly it's still, I gave a talk on this here in 2008. I was checking my phone here. And it was a crisis back then. It was fragmented and duplicative, and it's just obvious from your presentation here. And so, would a single payer publicly funded health system, is that the model that we could work towards, where it would just, eliminate so much of the fragmentation and the lack of interoperability, and I mean, it's just such a mess. It's just unbelievable. I appreciate that you have to do what you're doing, but is there a overall solution to this that we can work towards?
So I had a mentor a long time ago when I worked at ARC, and what she told me is that when you look ahead and see how much work you have to do, you have to look behind you and see how far you've come. And while it's still, yes, we're still in crisis, we didn't have all these services funded under Medicaid when I first started at NAMI. You know, we didn't have first episode of psychosis programs. We didn't have supportive housing. So there is a lot. But the other thing we have to remember is there's more people. That, you know, not as many people sought out care, and especially since COVID, the rates for depression and anxiety are way up. The one thing I will say is that, you know, I teach this class at the U, and one of the papers, small papers, is that every student takes a country in the world, and they have to look at it both from the health and the mental health side. And I will say that the mental health systems pretty much in every country around the world suck. I mean, they just do. You look at England, and you have kids who've been waiting way over a year to even access services. So it's not just here, which I don't know if that makes me sad or happy. I don't know. You know, it's like we're not in this alone, I guess. But so I don't think anyone's quite figured out, because I think generally speaking, people still don't view mental health as part of the healthcare system. It's something else, right? And whether it's we should just people away in institutions, just put them, you know, so they're not involved in our communities or whatever. But it really is a huge problem all around the world. And not many countries have figured this out very well when the students really looked at it. So I don't really have a magic wand to say what would actually work, but I think as we continue to see, you know, more things paid for under insurance, that helps. Grant money is, you know, that grant money is just hard to put that together, honestly. We need to be paying for things. And yes, things are a little different to pay for under mental health. I mean, even think about, you know, some of the presidential candidates talking about in-home services for people who are elderly, right? So that they don't have to, you know, actually, you know, lose their life savings, right? And things like that. So more work to do, but I have to say, I'm still optimistic. I mean, when I think about all that got passed, I'm like, we're making progress. Are we there yet? No. But I do take her words to heart, and I look behind us, and we've really come a long way.
All right, so probably time for one more quick question. So I know you said a couple, so you'll have to pick your favorite.
Yep, I'm picking one. So you said that in the arms worker that occupational therapists were added. So what would that look like, and how would you find to add that service?
So an arms provider could just hire an occupational therapist, and they'll be able to bill for them under arms services.
Same rate.
You know, I don't know how that part works, because I've never had to bill for anything. I have to rely on grants and donations, so you know, we don't get to bill Medicaid for what we do, or insurance. So I'm not sure about that. I just know that those teams can add them. So I thank you for coming. I'll stay after if there's any questions. I do want to say that don't give up hope, okay, please, and know that your individual story makes a huge difference, totally. Thank you.
Thank you.